Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Madrigal Pharmaceuticals.
Welcome to the second episode of Medscape's in-depth CME TV docuseries, Managing MASH in the Modern Era. I'm Taryn Winter-Brill, and over the next several episodes, we're taking you on a journey, meeting the pioneers, problem solvers, and disruptors who are reshaping how we detect and treat MASH at its earliest stages. Today, we're at the Liver Clinic at North Shore Gastroenterology in Cleveland, Ohio. It's here that Dr. Naim Alkhouri leads one of the busiest liver clinics and clinical research programs in the U.S. Not long ago, there were no approved drugs for MASH, only lifestyle advice and watchful waiting. Today, for the first time, we can change the trajectory of this disease with targeted therapies, guided by non-invasive tests and real-world data from clinics just like this one. In our last episode, Dr. Alkhouri walked us through how to use non-invasive tests to identify patients at risk for MASH progression. Today, we'll pick up that story and focus on what comes next. How do you choose and monitor therapy once F2, F3 fibrosis is confirmed? Dr. Alkhouri, we are delighted to be here. Thank you so much for hosting us.
It's my pleasure.
So in our last episode, I asked you to imagine a patient at risk for MASH who you might see in the clinic. Can you paint that picture for us again?
Absolutely. Our patient is a 59-year-old Hispanic woman with type 2 diabetes and dyslipidemia. Her medications are metformin extended release, 1,000 milligrams daily, and atorvastatin at 80 milligrams daily. She has a hemoglobin A1C of 6.5% and a BMI of 31, consistent with obesity. During a regular checkup, her primary care physician noticed mild but persistent elevation in her liver enzymes, AST and ALT, and steatosis was found on a subsequent ultrasound. She was then referred to the clinic to sort out the cause and severity of what they found.
Very vivid. Thank you so much. So what happened next?
So on labs, she had an AST of 55 and ALT of 44, and her platelet count was at 182,000. We calculated her FIB-4 index, and it was at 2.7, which signaled to us that she might have significant fibrosis and needed second-line non-invasive testing. We then did VCTE, and her liver stiffness was at 12.5 kilopascal with the CAP score of 340, which meant that she had both advanced scarring, advanced fibrosis, and severe steatosis. When you put that together with her other comorbidities, she was diagnosed clinically with probable MASH and F2, F3 fibrosis.
Okay, so the next logical question is, how do we treat her?
So for non-cirrhotic patients with MASH and F2, F3 fibrosis, we now have two FDA-approved pharmacologic options, oral resmetirom and subcutaneous semaglutide, always in combination with lifestyle and cardiometabolic management. This is a major evolution from just a few years ago, when our approach relied primarily on lifestyle modifications and managing metabolic comorbidities. Today, we can pair those efforts with therapies that directly target steatohepatitis and fibrosis and can potentially alter the course of the disease.
Let's pause here and highlight a critical shift in managing MASH in the modern era. Non-invasive testing is transforming how early-stage MASH is identified. Here, a 59-year-old woman with type 2 diabetes, dyslipidemia, MASH, and F2, F3 fibrosis has been clinically diagnosed using non-invasive tests. And for the first time, two FDA-approved therapies are on the table, oral resmetirom and subcutaneous semaglutide. In this next section, watch how Dr. Alkhouri frames treatment goals and starts to translate trial data into a plan for this specific patient. So, before we dive into drug specific details, at a high level, how do you frame your overall treatment goals?
So the goal is to reduce liver fat and inflammation, and especially to improve or at least stabilize fibrosis. So when I talk to patients, I tell them we're trying to do three things: calm down the inflammation in their liver, slow or even partially reverse the scarring, and most importantly, lower their overall risk for serious problems down the road.
That's really helpful. So, when you're sitting with this patient, what factors weigh into your treatment decisions?
Their cardiometabolic risk factors, how well their diabetes is controlled, their BMI, do they have tolerability issues, do they have preference for injections versus pills. Some patients prefer the simplicity of a daily pill, while others are comfortable with the weekly injection. But the foundation of treatment is still to make everyday healthy lifestyle and dietary changes, find ways to be more active, and then set achievable weight loss goals. Along with that, we focus on keeping diabetes, cholesterol, and blood pressure well controlled. The newer drug therapies for MASH don't replace the basics, they build on them.
So, how would you explain the treatment options to her?
So I would start by saying that we have two strong options: one that's a daily pill and one that's a weekly injection, and that both can help her liver but offer slightly different strength. Semaglutide leans more into weight loss and diabetes control, whereas resmetirom leans more into a direct liver targeted effect on fibrosis. Then we look at her priorities. Is she more concerned about her weight and blood sugar, or most focused on her liver scarring? How does she feel about injections versus pills? What are the common side effects? Once we've talked through those trade offs, we usually arrive at a decision together, knowing we can adjust over time if we're not getting the response we want.
And can you speak to the practical applications of resmitirom's clinical trial data?
Certainly. In the ongoing Maestro NASH trial, resmetirom significantly increased MASH resolution without worsening in fibrosis for 25 to 30% of participants after 52 weeks of treatment, compared to only 10% with placebo. And around 25% of treated patients achieved improvement in fibrosis by one stage or more, compared to only 14% in the placebo group. This happened alongside reduction in liver fat on MRI-PDFF and also reduction in LDL cholesterol and other lipids, so very strong lipid data. Safety was reasonable with primarily mild gastrointestinal adverse events. Resmetirom efficacy is largely weight neutral, but weight loss of at least 5% is associated with greater improvements in MASH resolution and fibrosis, even though it's not required to see benefit. Its antifibrotic effects are also consistent across other subgroups, including patients with and without type 2 diabetes, and also in patients with F2 and F3 fibrosis.
I see. And semaglutide also has an ongoing mass trial. Is that correct?
Yes, the phase 3 Essence trial showed that semaglutide treatment was associated with MASH resolution in a significantly higher proportion of participants compared to placebo, with the delta nearing 30% after 72 weeks of treatment. 37% of participants on semaglutide had improvement in fibrosis without worsening in MASH, compared to only 22% in the placebo group. Participants on semaglutide also lost about 10% of their body weight on average versus 2% with placebo. Again, the safety profile was good, with the main side effects being short lived and gastrointestinal related, mainly nausea and vomiting.
In the past 2 years, we've entered a new treatment era for MASH. Resmetirom became the first liver directed therapy approved for non-cirrhotic MASH and moderate to advanced fibrosis. And semaglutide followed as a GLP-1 based option for the same high risk group. In this next stretch, listen for the informal algorithm Dr. Alkhouri is using. What prompts him to add a second agent versus switch? And which signals tell him a treatment is working well enough to stay the course? And do you ever use resmetirom and semaglutide together or sequentially?
So right now, we don't have robust trial data on combination therapy, so combination use is still more of an emerging concept than a guideline-driven standard, but their mechanisms of action are quite complementary. Resmetirom is a liver-targeted thyroid hormone receptor beta agonist that improves hepatic fat disposal and fibrosis, while semaglutide is a GLP-1 receptor agonist that lowers caloric intake and improves weight and glycemic control. Our case patient's diabetes is reasonably controlled, and her BMI is in the low 30s. So, if I started her on resmetirom, I would reassess at 1 year, and if there's no response, I may switch to semaglutide. If she has a good response, I might still add semaglutide for its cardiovascular benefits. Now, the reverse can also be true. If I start with semaglutide, I would reassess after they've reached and maintained the target dose for about 1 year. If their fibrosis signal hasn't improved, I may add resmetirom. Of course, whenever we think about combining them, we still have to make sure the patient does not have contraindications to either agent.
Great point. So, what are the key contraindications and situations where these agents should be used more cautiously?
Semaglutide is contraindicated in patients with a personal or family history of medullary thyroid carcinoma or also MEN2 syndrome and should be used cautiously or avoided in patients with history of pancreatitis. Resmetirom should be avoided in those with decompensated cirrhosis, specifically Child-Pugh B or C, and it requires caution in patients taking high dose statins or in patients taking medications that are strong CYP2C8 inhibitors.
So far, we've focused on choosing therapy. Now we shift to another practical question. Once you start resmetirom or semaglutide, how do you know it's working? In this segment, listen for three key signals: steatosis, enzyme activity, and stiffness, and how Dr. Alkhouri monitors these to decide whether to continue, add, or switch therapy. So now let's move toward monitoring. Once you've started resmetirom or semaglutide, how do you follow patients over time?
The monitoring strategy for treatment response is the same for both and tends to focus on three things. One is steatosis reduction, and this is shown by lowering the CAP score or improvement on MRI PDFF. Two is activity reduction, so lowering ALT and AST, the liver enzymes, which suggest less inflammation and injury. And then three is fibrosis improvement. This is the most important. Here, we're looking for a reduction in VCTE liver stiffness by at least 25% from baseline as a pragmatic signal of fibrosis improvement. If patients are responding and tolerating treatment, we continue therapy and reinforce lifestyle measures. If liver stiffness improves by less than 25% in 12 months, we may consider adding the other agent. If liver stiffness remains unchanged or worsens, and there is no clear improvement in liver enzymes despite good adherence, then that's a red flag. In that situation, we'd consider adding the other agent or switching if tolerability is an issue, and then re-evaluating for other causes of progression. In practice, I check liver enzymes, a metabolic panel, and relevant safety labs about every 3 to 6 months. And then I repeat VCTE at about 12 months, and then every 1 to 2 years, depending on the risk and response.
And are there any monitoring nuances that differ between the two drugs?
No, not in terms of monitoring response, but there are some safety nuances. With resmetirom, I pay closer attention to thyroid function tests and regularly review other medications they're taking for potential drug-drug interactions. With semaglutide, I focus more on the GI tolerability, gallbladder issues, pancreatitis risk, and also renal function and monitor for acute kidney injury from dehydration.
So, we've talked a lot about non invasive tests. Where does liver biopsy fit into your practice, if at all?
A routine repeat liver biopsy is rare in my practice. I reserve it for clinical trials or situations where there is real diagnostic uncertainty. For most patients, non invasive tests are sufficient to track response, guide treatment decisions, and keep an eye on progression risk.
So, to close, what are the one or two key things you'd love our audience to take back to their clinics after this episode?
So, number one, in 2026, we now have two FDA approved medications for non cirrhotic MASH with F2 and F3 fibrosis. And we can identify these patients with non invasive tests using established algorithms. And number two, the biggest unmet need is not more drugs, it's implementing screening guidelines, staging disease, and starting treatment in appropriate patients. So, I summarize it as the three S's approach. S number one, screen. S number two, stage the disease. And S number three, start treatment.
Clear and practical. Thank you so much, Dr. Alkhouri. It's been such a pleasure speaking with you.
Likewise.
Across this series, we've been building a simple mental model: screen, stage, and start treatment. In this episode, you've seen what start treatment looks like: translating trial data into a tailored plan, monitoring non-invasively, and knowing when to adjust. Today's conversation highlighted a critical shift in managing MASH, moving from a wait-and-see approach to proactive early detection and treatment, using non-invasive tests to identify at-risk patients before fibrosis advances too far. Combined with lifestyle and cardiometabolic optimization, and now with resmetirom and semaglutide in the toolkit, we have a real opportunity to change the trajectory of disease. As we close, think about one change you'll make this month in how you manage MASH in your own clinic. On behalf of Medscape, I'm Taryn Winter-Brill. Thanks to all of you for joining us. Be sure to complete the post-activity quiz and evaluation to receive credit. And we look forward to seeing you next time as we continue to explore metabolic disease and MASH in the endocrinology clinic.